Good morning, everybody. It's a real pleasure to be here. So thank you for the invitation to participate for the first time in this conference here in this beautiful part of the world. So I will very briefly go over now what is the current clinical evidence for the Bioadaptor. I'm sure you've seen this slide before. In the first year, we know that for our current generation DES are superior to first generation DES and superior to BMS. However, after year one, we see for all of these devices an annual 2 to 3% event rate. When we look at the DES which we use every day in our cath lab, I'm sure it's the same here as it is in Belgium where I work. The Onyx, the Xience, the Synergy or Saro, all of them, when we follow them up after 5 years, etc., we have increasing rates of stent-related adverse outcomes. Of course, we still believe in and leave nothing behind to a certain degree. However, there has been no proven benefit to date. We know that in the absorbable scaffold technology, absorber, there was some disappointment. And even after it had completely resorbed at 3 years, initially it was thought to be 18 months, but 3 years. Even after that, we see this incremental rate of adverse related events. I know there's further studies ongoing, but of course, there's no proven benefit as yet. Same with the DCB technology, also promising, but as yet, the large study published recently in the Lancet showed really no non-inferiority in large vessel proximal disease, de novo lesions treated with DCB. So again, there's no definite benefit yet. So we're still treating most of our patients anyway in Europe with proximal lesions, de novo lesions with metallic DES. However, as I mentioned in my first slide, we have adverse related events. And this is pretty driven by certain different factors, the strut fractures which occur, inflammation, loss of vessel compliance, loss of vasomotion, the inability for the vessel to have adaptive remodeling, development of new atherosclerosis. So all these features really promote and drive the adverse cardiovascular events. So the Bioadaptor really was developed to try and restore vessel physiology and vessel function in order to try and address these deficiencies that we currently have. For those of you not aware of this device, so it consists of 3 helical sinusoidal strands, cobalt chromium, 71 microns in thickness, which are temporarily connected by a polymer, which eludes also sirolimus. At 6 months, this polymer is completely resorbed, allowing uncaging of this technology. So it really acts like a DES, a metallic DES, in the first 6 months in terms of use, and you'll see some cases later on. It is very easy to use. You get an acute gain, which is very similar to a normal permanent metallic DES, and you get low residual stenosis. At 6 months, you get unlocking of the mechanism due to resorption of the top and base coat of the polymer, allowing adaptive remodeling and maintaining a low percentage stenosis. And then this allows then for the evolution to dynamic support and restoration of hemodynamic modulation. You get restoration of pulsatility, compliance, and adaptive coronary flow. Since the absorb story, of course, has become quite difficult to develop and to introduce new devices into the clinical practice, and the ESC EAPCI task force developed this framework of things really which a device has to go through to get to a certain level. And if you look on the left-hand side of the screen, you'll see here there needs to be some preclinical work, bench testing, maybe perhaps some animal studies. Then you get the pre-market studies looking at a smaller cohort, a first-in-man study, which requires also invasive imaging present. And then the post-market, larger randomized controlled trials, larger number of patients with follow-up, etc. And if you look at the right, you can see how the Bioadaptor has really fulfilled all these different steps in the development. Lots of bench tests has been done, some mechanistic studies, the Bioadaptor RCT, which now we have a 2-year follow-up for, and hopefully will be published shortly. And then, of course, the Infinity Sweethearts recently published as well, the 1 year, their primary endpoint. So I will just go through a few of the data which we have. Obviously, we don't have enough time to go through all the data, but just to make it more clear in your mind how this works. So initially you implant the Bioadaptor, is no uncaging yet, so it's like a normal DES, pulsatility like you'd expect in a metallic DES. But then at 6 months, you get resorption, unlocking of the connectors, and you get then return of this vessel motion and pulsatility. Here's an image of one of the mechanistic studies on the right, and an animal cell on the left where you can see separation of these connectors. They're nicely covered by endothelium, and you can see this ability of the vessel to grow with pulsatility. So looking at the 2-year outcomes of the Bioadaptor RCT study, which was the first RCT looking at the Bioadaptor device, very briefly, this was performed in a number of countries. 445 patients were randomized to the Onyx or the Bioadaptor. There was quite a lot of imaging in subgroups, OCT, IVUS, etc. The primary endpoint was an intention to treat analysis looking at TLF at 1 year. And today I'll also present to you the 2-year data, which was presented at EuroPCR and also at TCT this year. So this is a relatively simple patient subgroup, not very complex disease as you would expect in this kind of scenario, mainly stable angina patients, but there were patients 1 in 5 with moderate to severe calcification. AHA lesion class B2C was almost 1 in 5, so not very simple lesions, but moderately simple lesion population. The primary endpoint was met with a TLF rate of 1.8% versus 2.8% for the Onyx. And I think what was very interesting was some of the sub-analysis performed in this smaller number of patients. The QCA, you could see on your left-hand side here, acutely, no difference between the Onyx and the Bioadaptor. And then at 1-year follow-up, you can see that there really is almost a significant lesser diameter stenosis in the Bioadaptor group. When we look at lesions at high risk of restenosis, the LAD with all the torsion and motion, small vessels, long lesions, you can see here that really the lumen diameter was significantly larger in the Bioadaptor group. And I think one very interesting finding on the imaging was the concept of restoration of pulsatility. So this is in-device pulsatility paired analysis. You can see here on your left-hand side acutely, so as you would expect in the region prior to the stent and post-stenting, there's good pulsatility, similar between the groups. In the in-device segment, the stent just implanted, there's little pulsatility. When you look at follow-up at 12 months' time, you can see here that in the blue we have the Dynamics Bioadaptor. Even in the in-device segment, there's return of pulsatility, which was not seen, of course, in the caged Onyx group. Another interesting finding, which was a bit unexpected, was this reduction in plaque volume observed, again, with the Bioadaptor group. You can see on the left-hand side, in general speaking, in every stent study to date, really, there's an increase in plaque volume behind the stent. But we saw that actually in the Bioadaptor group, this was very minimal. And when we look at the very high lipidic lesions, there was actually, a reduction in plaque volume with efflux of lipid from behind the stented region. The Bioadaptor RCT was published last year. This was the primary endpoint. Very briefly, the 2-year follow-up, the 2-year outcome. First of all, for the intention to treat population, you can see here that 2 years it was 2.3% for the Dynamics, this is target lesion failure, compared to 5.5% for the Resolute Onyx. So you can see widening and separation of the Kaplan-Meier curves. If we look at the per protocol population, we can see actually, for superiority, a significant reduction of 65% for TLF rates in the Bioadaptor group compared to the Onyx, driven by lower rates of cardiovascular death, lower rates of target vessel MI, and lower rates of clinically driven target lesion revascularization. And looking at these high-risk lesions, again, of restenosis, the LAD, small vessels, long lesions, again, a significant reduction in the LAD, and no incidence at all of TLF in small vessels or long lesions in the Bioadaptor group. And again, this kind of reflects as well in the significant reduction in target vessel failure at 2 years. So very briefly, the Bioadaptor RCT showed at 2 years a 65% reduction in TLF, with separation of the Kaplan-Meier curves between the Bioadaptor and the Onyx. When we look at lesions at high risk of restenosis, again, especially in the LAD, a significant reduction in TLF, only 1.9% versus 8.7% for the Onyx, and again, lower rates in the smaller vessels and long lesions. Based upon these results, the FDA provided a breakthrough device designation for the Bioadaptor in the United States, and there will be an IDE study, I believe, starting up very shortly in the United States. Now, looking at this study presented and published simultaneously at the ESC and in the journal The Lancet, just at the end of the summer at the ESC, the one-year outcome of the Infinity Sweetheart study. So what was the objective of this large study, 2,500 patients performed in Sweden using the SCAR registry, was really look at the safety and efficacy of the Bioadaptor in a larger population, a more representative patient population, high-risk patients with non-STEMI, with STEMI patients, ACS, and complex lesion subsets. The primary endpoint here was TLF at 1 year, powered for non-inferiority. However, there were also some powered secondary endpoints for superiority, and these were landmark analysis of TLF from 6 months to end of follow-up, 5 years, target vessel failure from 6 months to follow-up, and also in the group of ACS patients, TLF rates from 6 months to follow-up. Here's some key inclusion and exclusion criteria. I won't run over all of them, but as you can see here, there were some exclusion criteria, left main, bypass grafts, CTOs, in-stent restenosis were not allowed within the study, but otherwise pretty representative group of a population. So 2,400 patients randomized using the SCAR registry, which is a well-known way of performing these kind of studies, randomized to the Dynamics Bioadaptor or the Resolute Onyx. And as you can see here, there was 100% follow-up for patients in both study arms, which again is something that we don't frequently see. Looking at the patient baseline characteristics, we can see here that 76% of patients had an acute coronary syndrome, STEMI, non-STEMI, and unstable angina, and only 1 in 5 patients really presented with chronic coronary syndrome. We can again see here some complexity with some bifurcation lesions, some calcified lesions. The lesion length on average was 24 millimeters, and the percent stenosis was 87% prior to PCI. The LAD was most commonly treated. So looking at the primary endpoint, we can see here that the TLF rate was 2.35% in the Dynamics compared to 2.77% for the Onyx. And hereby the primary non-inferiority endpoint was met with a p-value of less than 0.0001. There's been a bit of criticism or questions regarding the non-inferiority margin of 4.2%, but even if it was 1.5%, you would get a p-value of less than 0.01. Looking at some of the powered secondary endpoints, this is from 6 to 12-month landmark analysis. We can see here for the target lesion failure on the left-hand side, a significant reduction for the Dynamics compared to the Onyx, with only a couple of events in the Bioadaptor arm compared to numerous in the Onyx arm. The same holds true for the target vessel failure landmark analysis. When we look at, most interesting, the ACS analysis, this is patients, about 76% of the patients had ACS in this study. You can see here that the significant reduction and plateauing of TLF in the Bioadaptor arm at 6 months. Up to 6 months, really, there's not much difference between the Onyx and the Bioadaptor, but after 6 months, you can see here clearly, separation of the Kaplan-Meier curves. What about the high-risk lesions, the LAD lesions, small vessel, and long lesions? Again, we can see here, LAD lesions, significant reduction in the TLF rate between 6 months up to a year. Same in the small vessel lesions and the long lesions. And I'll just bring your attention to the fact that between 6 months and 12 months, there were no TLF rates in small vessels or long lesions in the Bioadaptor arm. And you can see here the number of patients for long lesions, 714 lesions with no TLF rates between 6 months and 12 months, which I think is quite impressive. Looking at all subgroups, we can see here this consistency of lower rates of TLF, looking at all the different subgroups here. Some are significant, some have more a trend to significance, with overall a significant reduction in TLF rates between 6 and 12 months. So they may conclude with the Infinity Sweetheart study, a large scale, 2,500 patients, multi-center, 20 centers in Sweden, with 100% follow-up. We see here very low and non-inferior TLF rates at 12 months, which is the primary endpoint. but a significant reduction in TLF and TVF, and even flattening of event curves, after 6 months in favor of the Bioadaptor in pre-specified powered landmark analysis. And especially a clinical benefit in high-risk patient groups, ACS patients, also LAD, small vessels, and lung lesions. As I mentioned, this was published as well in the Lancet simultaneously during TCT in October. So may I conclude this presentation by saying that the dynamics are suggesting that the dynamics Bioadaptor presents a new approach with a design and mechanism of action aiming at reducing the annualized rate of 2 to 3% of device-related adverse events beyond 1 year. We now have got 2 large randomized control trials confirming this consistent low and plateauing adverse event rates after unlocking of the device at 6 months. And we would suggest that perhaps this restoring of hemodynamic modulation in the affected artery really is the reason behind these reduced event rates. So the 2-year outcomes from the Bioadaptor RCT and the 1-year outcome from the Infinity Sweetheart support the effectiveness of the Bioadaptor and potentially offer an advancement over existing treatment options. Thank you very much for your attention.